thanks everyone for joining us for our Institute for Addiction Science Distinguished Speaker Seminar Series. My name is Adam Leventhal, and I'm the director. I'd like to give a little bit of information about our institute first, before I introduce our distinguished speaker, Dr. Zapolski. So the Institute for Addiction Science is a transdisciplinary academic unit here at USC. We are sponsored by the School of Social Work, the Keck School of Medicine, and the School of Pharmacy, but we also have members in 4 other schools. And our mission is to engage in transdisciplinary collaborative research, education, community engagement, and now we're branching into clinical services as well, because we believe that we need to break down silos amongst different fields so that we can make progress and start to reduce and end these addiction epidemics. So I'm really excited because we have a wonderful distinguished speaker today who engages in transdisciplinary research. And you will hear about her transdisciplinary research in a minute. So a little bit of background about Dr. Zapolski. Let me see, I had your bio. Oh, here it is, there we go. So I want to make sure I get everything. Okay, so Dr. Zapolski is an associate professor with tenure in the Department of Psychology at the Indiana University Purdue University, Indianapolis, IUPUI. So she's director of the PRISM lab. So PRISM stands for Prevention Research in Substance Use and Minority Health. And her lab examines individual, interpersonal, and socio-cultural factors related to developmental risk for substance use and other health behaviors. So particularly among minority populations. And Dr. Zapolski has a second line of research examining the effectiveness of school and community-based interventions to reduce substance abuse and related emotional and psychological problems among adolescents. And within her body of work, she also conducts studies on the adaptation of adolescent interventions to be culturally responsive to the needs of minority populations. Dr. Zapolski has published a number of different articles in many prestigious journals in our field. And her work really is a very nice bridge of impact and being interesting, right? And intellectually stimulating. So I'm just really excited to have her, and I'll turn it over to Dr. Tamika Zapolski.
Thanks so much, Adam. Let me share my screen. Get going. All right. Hopefully everyone can see my screen. So so I am going to be speaking on substance use and among Black youth, and looking at it through a socio-ecological lens. I have no disclosures or conflicts of interest to disclose. And like Adam said, so my lab that I'm the director of is the Prevention Research in Substance Use and Minority Health Lab, PRISM. And like you said, we really are focused on developmental risk for substance use, mainly adolescents, young adulthood, and really trying to focus on risk protective factors among minority populations. My passion and area that I've been working in for myself a lot is among Black youth and young adults. And so that work I'm going to be talking about today, but we also look at other minority populations. So I have students that are really interested in understanding these processes among immigrant populations. I have others that are interested in gender and sexual minority populations, Latinx communities. So we also do work in those areas, and you'll see that in my CV. But like I said, today I'm going to focus on Black youth and young adults. And then I really like to make sure my work's translational and to be able to be impactful for those that we work with. And so because I do a lot of work with adolescents, I try to figure out the best ways to be able to help prevent engagement, substance use, and related outcomes, or at least mitigate risk and reduce it. And with that, I have been working with schools and juvenile justice to try to find places where kids already are to be able to decrease issues with access to services and issues with insurance. And so I've been able to partner with several community organizations, particularly schools and juvenile justice, to be able to do that work. I'm not talking about that today, but if you have questions about that work, please let me know, and I can try to answer those questions. So for today, we really want to focus on understanding substance use risk among Black youth and young adults, and understand that from a socio-ecological framework. And so I had 3 learning objectives. One, really just understanding the landscape of substance use among minority populations, among Black population. Also to be able to, sorry, I'm gonna go backwards. Maybe not. Understand that risk, sorry about that, to be able to understand different frameworks for understanding substance use. And then lastly, talk about some of the work I've been doing on risk protective models for Black youth and young adults. And so just give a little background. So compared to white respondents, Black respondents tend to report lower rates of alcohol and tobacco use, and comparable or higher rates of marijuana use or cannabis use. And I'll look at that with the National Study of Drug Use and Health. This is past year use. And you can see that compared to white respondents, you do see lower rates of alcohol, tobacco, and again, comparable right now, a little bit higher rates of marijuana. This is 12 and older. See similar trends when you're looking at just 12 to 17, where you have, again, lower rates of alcohol, tobacco, and again, this one, comparable rates of marijuana. You see this also looking just developmentally across from like 11 to 35. This first box up here is alcohol use. The top line is going to be for white participants. And then you have Hispanic and Asian, and then the bottom right here is African American or Black. So you see that the trend, the peak of alcohol use does not get to the level for sure of what we see for white youth and young adults. Same thing for heavy drinking. And then you see a little bit different trend here where it's kind of flat, kind of general increase, though low for tobacco. And this is that crossover where we're seeing that there is at times comparable and then at other times higher rates of marijuana or cannabis use among Black youth. And this with marijuana is something that's interesting to me also, with just changes in perceptions of risk for marijuana, legalization of marijuana or cannabis across different states in the United States. And so we found that, you know, if you're looking just not developmentally, looking across different decades, that there is just a trend when we're looking at white Black differences, where there was a higher rate of marijuana use among white youth until like the 1990s. Then that gap narrowed. And like I said before, we are now seeing trends where African American or Black youth are reporting higher rates of use. So all this to say that, you know, alcohol and tobacco, pretty consistent lower rates of use, marijuana, comparable, and sometimes higher rates. But what we do find across the board is that even if we're looking at comparable levels of use, that African American or Black Americans report higher consequences or greater consequences from use. This for alcohol, I did a review in a theory paper that was published in Psych Bull in 2014 on this topic. And we do find that across development that African American or Black youth and adults report higher rate of problems from alcohol use. This includes liver cirrhosis, alcohol-related mortality, alcohol dependence symptoms, as well as a plethora of social problems from use. Similar to cannabis, even though again, we see that there is this comparable and at times higher rates of cannabis use, there's also risk of progression to alcohol or cannabis use disorder among Black youth compared to their white counterparts. And even at comparable levels, again, we're pointing to those social problems. There's consistent evidence that Black Americans are at greater risk of having legal problems from use, even if they're using at the same or even sometimes lower rates of use. And tobacco, similar finding that even though in general, Black Americans report lower, fewer cigarette smoking and smoke at a later age, more likely to die from smoking-related diseases. And so why is this happening? Some of it, as I probably alluded to with the legal issues, but some of it is environmental. Some of it's cultural. There are differences in prevalence of alcohol use, but the norms and issues among those that do use are different among the Black community. So there's different sanctioning within the community for alcohol use in particular that you don't find in some other cultural groups. So there's some differences there as to why there might be more problems even if they're not using. There's also some studies look at metabolic issues or differences across groups. But one thing that we focused on in our lab is also looking at it might be the byproduct of the type of substances as well as the course of use. And so one of my graduate students is really focused on understanding the concurrent use of different substances among Black youth in particular. And we can see that there's just different trends, not just so with single use, but the combination of different substances that individuals are using. And we see this across racial groups as well. And so my graduate student, I'm now a professor at St. Louis University, was looking at this idea of single versus concurrent use using the data from the National Study of Drug Use and Health. And what she found in our study is that there were differences in probability of using different types of substances. So similar to what I said about marijuana use in general, we find here greater odds of the African-American or Black youth engaging in marijuana only use, but also higher rates of alcohol and marijuana use compared to their white or Caucasian counterparts, peers. And so again, this might be a reason that there might be some problems as well as what happens when you're using multiple substances at the same time. Does that increase risk? When are they doing it? And so we don't have all those nuances, but this does point to that there might be some combinations that are important to look at. I have another colleague that I worked with that does a lot of work with blunt use, which is a combination of marijuana and cigarettes, not using cigarettes and also marijuana, but taking cigarettes and then putting marijuana inside of it and smoking it in blunt form. And so there's a lot of studies out there on what that does to the body and the chemical reaction of having those two substances at the same time, which is very common among the African-American community. Anecdotally, a lot of the research that I do in the community when I talk to Black youth is that some of them just solely use blunts. And so understanding that specific type of use is important and has been not researched as much in the literature as single substance use. So it gives you a little background as to where we are looking at just prevalence and trends of substance use among Black youth and young adults in particular. I want to move now to think about theories or models for understanding substance use risk. So one of them, early one was Petraides in 1995 that said, okay, if adolescents, they're using substances, like what are the reasons, what are factors and important to consider? And these are interpersonal, so things within the individual, their attitudes or beliefs about substance use, as well as religious involvement in school attainment or involvement, as well as influences from social factors such as peers and family. This was expanded by Donovan in 2004 to include those personality factors, added some more behavioral factors such as delinquency, aggression, looked at family and peers, but separated those out and looked at some other nuances within that, but also expanded to look at community. So do you have drugs available to you? And one thing, that first bullet point there that's also important is socio-demographic variables. There are also differences based on gender, age, income, and race, ethnicity. So it's important to look at all these factors as well when thinking about risk. And so there have been some studies that have looked at, okay, if we look at these different types of risk factors, as well as protective factors, do they help understand variability or account for who is engaging in substances across racial ethnic groups? And what these studies have shown is that not all of them do a great job, but they also differentially account for risk across groups and generally have the lowest predictive ability for Black youth and young adults. So this study by Vega accounted for 34% of classification of lifetime alcohol use among Black youth. This was by Biersman in 2005 and counted for about 10% of variance in binge drinking among adolescents. You'll see it wasn't great for across the board, but was again lowest for the Black respondents. And so one thing that my lab and myself have been thinking about, like, okay, well, what are some other things that we need to consider? What are some other models or theories that we can use to help understand what are factors that are important when thinking about risk for substance use among minority populations, Black youth in particular? And so 3 of them that have come up are the cumulative disadvantage theory, which really talks about early advantage and disadvantage, broadly speaking. This could be trauma, resources, but how these things impact risk for substance use and other health outcomes over time. There's also then, more specific to culture, the minority stress model that was first created for understanding disparities in among sexual minority individuals, but really talks about the impact of discrimination victimization on risk, as well as internalizing those experiences and how that can impact health. And then there's also the weathering hypothesis that talks about just living in a race conscious society and how that can just wear and tear on the body, not just psychologically, thinking about that, but also internally and how that impacts stress hormones, inflammation, just the biology of the body to be able to regulate, and how that can also impact health, physical health, as well as mental health. One last one that I have also been thinking about incorporating in my work is a socio-ecological model that incorporates these ideas from Donovan and Petrades, as well as tries to incorporate some of these other ideas from these cultural theories. And what I like about the socio-ecological, again, is it talks about the interaction across different systems. So we have the individual level, the personality, expectancies, genetics is even in there. You have the interpersonal, so you have the peer and parent, which is of course really important for adolescents and their risk for substance use. You have the community, so access to drugs, right? That was that one last one that was added for Donovan. Poverty, socioeconomic status, advertisements, violence exposure, cultural norms, all those things within the community neighborhood factors are important as well. And then we have societal norms, policies, changes in legalization of marijuana, changes in the legal age to be able to use alcohol or purchase alcohol and use alcohol and marijuana and tobacco. All those are important. But one thing the socio-ecological model doesn't touch on that those cultural factors or cultural models did is culture specifically. In this case, I want to talk about racism, because racism, as Dr. Kamara Jones talks about, is a system of structuring opportunity and assigning value based on the way one looks. And this allows advantages and disadvantages across the systems, across how you feel about yourself, the individual, the interpersonal, what your parents, your peers say, believe, do, their experiences as well with racism, the community that you reside in. We'll talk about structural racism and how that also affects the societal issues, and again, permeates through all these systems. And so that is something that has been missing in these more comprehensive models, is how do these kind of cultural factors, specifically racism, impact risk when we couple that with these other factors that we have known to be important across the decades. So I did a study with Jean Brody and colleagues at the University of Georgia. My graduate student at the time, Devin Banks, and myself worked on a paper that was trying to be able to, a first step in being comprehensive, to add these well-known risk factors and protective factors with racial discrimination or racism in the model. And so we called it Why Now? Examining Antecedents for Alcohol Use Initiation among African-American adolescents. And so again, we looked at these established, more, we assume, cross-cultural factors. So peer influence, parent influence, interpersonal factors, with also adding in racial discrimination. And we look separately for initiation of marijuana, cigarettes, and alcohol, given, again, those differences that we see in prevalence rates. So we didn't want to combine across because youth are engaging in different substances at different times. And so it's important to separate those out. And we also looked at developmental changes, so differences. So early adolescence initiation, really early in life, early in adolescence, mid-adolescence, 16 to 18, which is when people generally start using substances, and then late adolescence, 19 to 20, to see if there are differences based on development. And this was using data from Jean Brody and the University of Georgia that had 500 rural Black youth. And then they had the data from over 14 years, from age 11 all the way to 21. And there was measures on SES, social factors. We had attitudinal factors, so things, beliefs, religiosity, and social engagement was in that level. Interpersonal, so externalizing behaviors, self-esteem, depression, anger, and then we had a cultural index, which was a measure of racial discrimination. We tried to have these in those different areas based on the previous models discussed earlier. And so just look at these results. So this was not looking at specific development, but initiation at any point in time between 11 and 21 for cigarette, alcohol, and marijuana. We found that the risk factors for cigarette were male, interpersonal factors, and racial discrimination. For alcohol, family SES, which was protective, and then racial discrimination. And then for marijuana or cannabis, it was male and racial discrimination. So I'll get to a slide of interpreting, but again, you're seeing racial discrimination across all three substances. And for us, that really highlighted how that is an important factor to consider in research, even when you're combining across these cross-cultural or these well-known risk factors. We then looked across development, and you'll see different trends here, different effects. So we found this was for alcohol. For early initiation, it was SES as protective, and we found that across the board. None of the other factors actually came out in this model as being significant. Marijuana initiation, we found attitudinal. For early, we found several factors: male, social, attitudinal, and racial discrimination. For mid-adolescents. And then for late adolescents, it was male and social factors. Lastly, cigarette. We found male, attitudinal, interpersonal for early, male and social for mid, and male and SES for late adolescents. So what are the implications of this? Like I said before, racial discrimination was a consistent factor that came out as being significant in predicting initiation across when we're collapsing across developmental stage. And so this was showing us that even when it's including with these other well-known factors, that is pulling out as being important. So it's something to definitely consider to be able to incorporate in research, as well as thinking about it for intervention perspectives of how do we incorporate this stressor of this experience of racism into programming to decrease risk for substance use among Black youth. The second one was looking at developmental period. And so this highlighted there were differences in what risk factors were coming out as important based on the age of initiation or the age developmental period that we were looking at. And so for early adolescents, the attitudinal was predictive for marijuana, and both attitudinal and interpersonal were predictive for cigarettes. So that's saying, okay, what are these things inside the individual, their beliefs, how this is influencing early initiation. Mid-adolescence, there was still that attitudinal risk for marijuana, but also social and discrimination, racial discrimination were predicting for marijuana. We also had social for cigarette initiation. So again, this is saying, pulling back to maybe these social, these environmental factors might become more important or become maybe an important predictor, at least to consider for risk during mid-adolescence, which makes sense. I mean, we're starting to get a little older and being around peers and having these more experiences outside of just the person and what they think about the substances appears to be something to consider. And then late adolescence, these social factors are also pulling out as being something that could be important, particularly for marijuana. Now, a question you might have is like, okay, well, what about racial discrimination? If it came out in AIM-1, what happened in AIM-2? Why didn't we see that as a robust predictor across the board, or at least more so than just with the marijuana and mid-adolescence? We believe this might be due to the lack of inclusion of racial discrimination as there was when it was assessed. So it was not assessed during early adolescence. It was only assessed during mid-adolescence. So that's why you saw it in AIM-1, because it was collapsing across age, but not in AIM-2 when we didn't have it for early. We did have it for mid, right, and for late. And what we were able to do is start to look at that racial discrimination measure and the scores that people had on that at that mid-adolescent period when it was first assessed. And we found that the highest scores were for those that were actually early initiators when we assessed it at mid-adolescence. And so that might signal that it might be early experiences of racial discrimination that might be really predictive of early use. And so we weren't able to assess that around early initiation. And so this came up as something to be able to consider in future research, to really start thinking about how does early exposure to racism, racial discrimination impact early substance use initiation, as well as health outcomes across time. So that's just some of that work that we did with looking at kind of a first go with looking at more of a comprehensive model for substance use among Black youth. But we've also worked on expanding outside of that because racism is multifaceted. Like I said before, it's a system of structuring opportunity, assigning value, and it happens at many different levels. One of the levels that Dr. Jones talks about is the institutional or structural level. And this is differential access to goods, services, opportunities that is based on race. And so we find that there's differences in where substance use services are, where mental health services are, where pollutants or just access to resources are based on one's race. Policies, procedures are different based on the percentage of some racial groups in society, in our society. We do find out with redlining and different things about zoning practices. And so those things are important. They do impact health outcomes. And so being more strategic and understanding that and the nuanced nature of that within substance use is something important to consider. And we have begun to do work where we're assessing for those structural levels of discrimination and how that does impact health among minority youth. The second thing that we have looked at is this person-mediated, but more in a more nuanced manner. So this is the assumptions about the ability, motives, or intent of others by race. This is probably what I would say is generally what is measured in self-report when we think about discrimination, or even when people think about discrimination. It's someone treating someone differently or thinking differently about someone because of their race. But there is also this idea of racial microaggressions. And this is a little different than just someone treated me differently because of my race. These are more brief, everyday exchanges that can send demeaning messages to the target group. This can be often subtle and indirect and be fairly difficult at times for the recipient to know, was that a slight? Was that saying something that was offensive? Should I be offended by that? Because it's not as direct, and it can happen in many ways. It can be verbal, it can be nonverbal, it could be behavioral. So looking in a room and only seeing pictures of one minority or one racial group and be like, do I belong here? Or only listing males and you're female. Like, is this a subtle kind of hint that I do belong here or I don't? And then also for the recipient or the person that's engaging in the microaggression, it also can be automatic and unconscious and sometimes unintentional. Sometimes it is intentional, but because of that, there is this kind of vagueness about it, or uncertainty about, did you do it? Did I mean to do it? But regardless, it usually leaves the target feeling unwelcome, isolated, unsafe, and alienated. So if this is a new term for some of y'all, I wanted to just show us a very short video on racial microaggressions coming from some adolescents.
Oh, you're so pretty for a Black girl. Oh, she has a Jew nose. Oh, your hair would look so good if it was straight. Jews are so cheap. Why are you so cheap?
Do you speak good English?
How are you an Iraqi Jew?
I think the person saying microaggression kind of doesn't really think about it.
This person who said it was my friend, and I was astonished that they would say something like that.
You don't want to make a big deal about it, but then it's also you just said something that offended me, so I feel like I should speak up.
Because they're micro, because they're very subtle, they're small, you feel like you don't have a reason to be upset. You're overreacting, and people even can make you feel that way when you bring it up. They're like, oh, you can't take a joke.
You're making too big of a deal of this. Why are you overreacting?
Don't take it so seriously. It was just a joke. Chill out. Say oh no, I actually love Black people. I love people of color. They try to just minimize the situation.
If someone feels hurt by a microaggression, it shouldn't just be pushed to the side.
It definitely has negative impacts and leads to people disliking who they actually are. Those kinds of subtle offensive comments can build up over time, and they can have like a deep psychological effect, and they can make you feel bad, and they can make you doubt yourself.
We try to just use jokes to like make things less awkward or like ease social experiences, but it is important because you need to like be aware of what you're saying and like who you're speaking to.
Think of what you say and how it can affect the person you're saying it to.
So yeah, so we've been starting to do more work on racial microaggressions because, again, they're subtle, they're small, but it's kind of death by 1,000 pricks of how that impacts someone over time, is particularly youth, that they're still trying to figure out who they are and developing their sense of self with all this also going on. And so we have started doing research on understanding racial microaggressions. So you might have seen in there that there was a study saying how many times people experience a racial microaggression. It was like 290, I believe that finding was in 90 days, but that was with college students. There was recent study in 2020 that came out saying that adolescents, I believe it was Black youth, reported experienced 5.9 microaggressions each day. So again, it's one of those things that if it's happening that often, how is that impacting psychological health as well as risk for substance use and other health outcomes? And so we have a study, my graduate student, Rochelle Clifton, is right now about to start her dissertation that's going to be looking at daily assessment of racial microaggressions on substance use and depression, anxiety among Black youth. We also have looked at racial microaggressions among young adults. And again, racial microaggressions are a newer term on the scene, but also being able to think about this within a broader picture of more comprehensive other stressors that are going on in people's lives. So is this important? Is this still important or an important risk factor accounting for these other stressful events that people experience? And so we did a study looking at trauma and looking at racial microaggressions to see if it provided unique prediction in problem alcohol use and cannabis use among a group of a sample of Black young adults. And we found it did. It predicted above and beyond trauma for both alcohol as well as cannabis. So again, these are kind of our first studies to show, is this an important factor to consider? Is it an important factor to consider above other factors? How often is this happening? What is the association with different health outcomes? And so that information will be helpful, right, as we think about prevention and intervention, things to be able to acknowledge and say, hey, these things are happening. How are you coping with them? How are you dealing with them? As well as, can we stop them or decrease them from occurring? So work with allyship and being able to decrease just exposure and the prevalence of this type of discrimination is also important. We've also started doing work on vicarious racism. So this is just seeing discrimination, racism happening through social media or through telling stories with the way that people are using Facebook, YouTube, Twitter, TikTok. We're just exposed to so much information. The George Floyd murder is one of those, and the trauma that causes of seeing that is also impactful. And so we're also measuring this type of racism as well in the work that we are doing in the lab. And so that just brings me just to talk about this one study that is just underway that pulls together some of these ideas. So this is looking at racial discrimination, racism coming from different angles. So we're looking at vicarious, we're looking at microaggressions, we're looking at macroaggressions, or just the more we say everyday kind of person-mediated discrimination. We'll have items on there, structural racism, but see how do these different forms of racism impact the health of Black young adults, or Black youth, sorry. This is for 16 to 18. Not only affect them psychologically and behavioral with substance use, but also how does it get underneath the skin, going to that weathering hypothesis that this kind of wears and tears in the body. How do you deal with that, not just externally, but internally? And so we are collecting blood samples from the adolescents to see how is it affecting stress hormones, We're looking at inflammation. We're looking at cortisol. So seeing again, do these different types of stressors impact the body, and how does that impact self-regulation, negative affect, substance use, to get a better idea of the flow, the progression, what are all the mechanisms involved. And that way we can have places of intervening, and one, just knowing, hey, this is what's happening, but also how can we intervene, and what are different ways we can help slow down or stop that process. The last thing I just wanted to mention is that it's not just about the risk, right? But it's also about the protection, the resilience. And the Black community is a strong community. And so understanding that there are also things that are going on that that people are engaging in that are helping, right? Without sometimes even external right forces of being able to cope and deal with the stressors and experiences that they're experiencing. And one of those is racial identity. This has been shown to be directly promotive on health outcomes for Black individuals. There's a lot of studies that show racial identity to be helpful in reducing anxiety, depression, increasing self-esteem, but also mitigate risk for health outcomes as a consequence of racism. But however, racial identity is multifaceted. So there are sometimes people just say, like, how strongly do you identify with being Black, or how much do you like being Black, or any other racial ethnic group? And that's one way to do it, but there's also different ways that racial identity manifests itself and develops. And so research has started to take this multifaceted approach to looking at racial identity. There you go. Racial identity. And my graduate student, Rochelle Clifton, has been doing this for her thesis, her prelims, and now also her dissertation, of looking at racial identity profiles and how that can be promotive, protective, as well as sometimes a risk factor for our health outcomes for Black individuals. And so I just want to show some of that work that we're doing. This was again from her thesis. So this was with Black young adults. Her dissertation will be with Black youth. And finding that this was using the MIBI, and which is the index of Black identity for just Black individuals. And so there are, I can see on here, 7 different subscales of the MIBI, and how people fall on those can put them into different profiles. And across several studies, there had generally been like 4 profiles that have come up. Similar to her study, there's a race focus that individuals are connected to the Black community, Black culture, and aware of racism specific to Black Americans. There's this multiculturalist where people are aware of race, but kind of think about it as an overall, people have an overall positive view of being of Black individuals. There's the integrationist where people are not necessarily connected to Black culture, but focused on we're all shared, we're all human beings, we all have similar, human qualities. And then there's also an undifferentiated where individuals don't really kind of identify with race or think about it too much. And so these were the 4 that came out in our work, and again, similar to some other studies as well. But we also found that, I went to that last stage, that there were some differences in how it predicted health outcomes. So we found that the multiculturalist actually was promoted for academic motivation, depression symptoms, but was a risk factor for cannabis use among these individuals in our sample. And that the undifferentiated was also, though marginally, associated with lower academic motivation. When we looked at the outcomes, which was depression, anxiety, and substance use as a consequence of discrimination, we found that there was a moderating effect, that there was greater risk for substance use among actually the race focused and undifferentiated, but lower risk for the integrationist and multiculturalist. I don't have time in this lecture to go into all the details as to why that is, but one of the take-home points was, hey, there's differences in how people's racial identity manifests itself. So one, that's important to know from a clinical perspective, but 2, that can sometimes be protective, sometimes be risk factor. And so being able to talk about it and talk about the different ways in which people identify themselves and how that is important for understanding health and risk. And from a clinical perspective, it can be just knowledge, not necessarily trying to change the racial identity, but being able to understand why it might be impacting them the way it is. So I'm gonna stop there. That gives, again, it gives you a kind of overview of what we've been doing in our lab. Also just kind of understanding of substance use risk among Black youth and young adults broadly, and also some understanding of different ways of theories and frameworks for understanding risk for substance use among Black youth and young adults. I want to thank my lab, the PRISM lab, collaborators I have at UGA with CTAPs, as well as colleagues I work with here at IEPUI in the Adolescent Behavioral Health Program, as well as funding for the projects that I've been working on through NIDA and the Addiction Screen Challenge. Thank you.
That was a great talk, Tamika. Yeah, like I haven't seen too many talks where someone is so interdisciplinary and they cut across different areas, but then they dive deep into them. Usually when people do that, they're kind of surface level, but you kind of like effectively dove deep into each of these, and a lot of your research is interestingly like kind of unpacking, going beyond just like a unifactorial constructs and in multiple different areas. So anyway, I really enjoyed your talk. And I believe everybody listening did as well. So let me go ahead and we'll start the Q&A section. Let's see here. I think I saw, please put your questions in the chat. Let's see. Excellent talk, bravo. Yeah, people are putting examples of microaggressions as well. Yeah, that was a really great video too, to kind of, it's good for academics to see that, you know, because we sometimes get disconnected. Well, I will, you know, ask a question. So, you know, you mentioned George Floyd, right? And then, you know, even before that, with the election of Donald Trump, and, you know, a lot of things were happening that were publicized in the media. And, you know, things that continue. I thought it was really interesting about your, I don't know what you called it, vicarious discrimination or what, but I'm just wondering, like, in terms of how you're thinking big picture, what the field needs, given the context that we're in, where we were recently, you know, just tell me, I mean, you've been doing this research for years, you know, multiple presidencies, but anyway, I just kind of want to get your thoughts about what you're thinking in terms of the context.
Of like Zoom and things like that? Or...
No, oh, no, sorry, sometimes that don't make sense. No, I mean like the racial discriminatory context, okay. You know, there were policies and travel bans, you know, at the beginning of the Trump administration. So a lot of this kind of became much more to the surface than, of course, you know, last summer with police killings. But I'm just kind of wondering how this factors into where you see the field going in this area of Black youth and substance use and mental health.
Right. So it's one of those things from, I would say, the Black community is like, yeah, it's always been there. Like, this isn't new from the last year or, you know, last 2 years. It might be some of it more visible to a certain extent, but on a daily level, you would say it's kind of been what's happening. Now, things might probably changed with our last administration, particularly with some groups experiencing heightened risk and experiences than maybe in years prior. I would say from a research perspective and the field, what it has done is those that weren't aware are now aware. And so those discussions, as a minority researcher, kind of the first stage is trying to be like, this is important. This is important. Why? And so I feel that these events have been able to decrease how much I have to say, like, hey, discrimination happens, before people might be like, oh, we had a Black president, things are okay. Mm-hmm. And so you don't have to sell it as much as you had to in the past. Yeah. and with that being said, now we have funding and more research and more people doing it. And so you now have that data like, hey, this is happening. It's happening all the time. You know, we can say 5 times a day for kids.
Yeah.
Not only that, this is what it's doing to their system. And so then I think it provides more, you have that empirical evidence to say, this is where we need money so that we can intervene, that we can have, you know, policies and procedures to stop it from happening. And it's not just one group, right? These things, I say minority health is, it impacts everyone. And so you don't have to try to focus it only on Black youth to be impactful and to be helpful for a large population of individuals.
Yeah, absolutely. Thank you. So we do have a question from Neo. Sorry if I got your name wrong. I know we know each other. Jay Brew. So can you please discuss intervention implications for the various constructs you measure, such as the blood samples, racial discrimination at the individual level? And then there's a couple follow-up questions. I don't know if you want to do them in order, Tamika, or you want to
Yeah. So no, that's a great question. So, you know, one thing when I was doing it, I was like, I don't want the goal to be, hey, we know that there's stress hormones and that there's inflammation, so let's give people a pill or something to just kind of bit a band-aid on what's happening. It's more of, you need to know the severity of what's happening and how it's impacting the system, so that we can say there's more reason to do these things, but also how changes to the system impact so much of a person's just life trajectory. There's new work on telomeres and just aging and diabetes, hypertension, all these things that are also disparities among the Black community in particular, could be partly due to these things that are happening, right? And so I think it provides those mechanisms to say, hey, this is one of the reasons why it's happening, to one, again, like I said, policies ultimately to stop it from occurring, but two, it could be points of more proximal factors, be like, hey, are we decreasing something? Are we able to reverse or be like, okay, well, we've slowed down the stress hormone. Oh, that's great. Okay, so this is working. We don't have to just wait to say, oh, is someone using substances? We have these other levels and places to see, are the tools we're doing having an impact?
Yeah, I understand. Like a biomarker too, instead of waiting for the Jackson Heart Study to publish another study, you know what I mean? Like that ends in either cancer or heart disease.
Exactly.
You could test interventions and policy effects. And if you're seeing movement on some of these outcomes, that's really cool.
Good for kids, right? I mean, I don't want to wait, say, hey, if I do this, you know, in 20 years, they're not going to be doing something, or adult outcomes, it'll provide, you know, more proximal marker. Yeah,
absolutely. And so let's see the follow-up questions, see if you answer them. If we see increased stress in blood samples or racial discrimination, what can we do about it at the person level?
Sure, yeah. So, and that's something that we're actually working on, is to show what are those factors that are helpful to decrease that stress, right? I'm actually working on a large just review paper of what people have done within immunology, outside even just discrimination, but stress in general, like what is it doing and what are the levers people have done to be able to reduce, slow down, in some case reverse some of the effects it has on the body. And so some of those things that we have started to look at are just coping skills, mindfulness, you know, those things have been shown to be helpful. Social support has been shown to be helpful as well. So I think there are things that people can do individually. Some of it's community based work that also is helpful to be able to impact those body changes.
Yeah, okay. For sure. And I think the other thing that you bring up about microaggressions too, is just the pervasiveness. And there's other forms of discrimination that are like so many times a day, or other social determinants of health. Why hasn't the field gotten here yet? Right. And I'm just like, wow, I haven't seen it, right, in substance use and addiction science. other fields have been doing it. But I mean, yeah, what do you think is happening, and what do you think are the key? It seems so important, right? Because, I've thought about this and designing experiments, even just like being the statistical minority, like a Black person walking into a waiting room for one of our studies, and there's just a bunch of white people there, it just happens, but that plus microaggressions plus other things that are so many times a day. I don't know. It seems so important and understudied. Yeah, so maybe you can comment on that.
No, I would even say among the community. So, we, my students will, now that, these are terms we use. And so go out, and I know one of my grad students worked in the VA, and she was talking to them about microaggressions, and they're like, that's what it is. Like, they're like, it's been happening, but I don't know how to say, like, what do I say when someone says something? I'm like, did you hear that? And so it kind of helps them too, kind of like, that's a name, a label to what's happening. And so I think that also is an example that it's happening, but people weren't labeling it that, or not knowing what to do. And if you don't have a label for it, it's hard for research to be able to, go anywhere with it. But I would say which is kind of coming to someone's question here about measure, I think where we are is that we know it's happening, but it's so complex and multifaceted that it's hard to figure out how to measure it well. So, some of the measures that I have used is like past year or past, like, how do you quantify something that happens so often into a self-report on the lifetime or the past year, or even, the past 6 months, it's just hard to be able to know, like, how accurate those are, and also how many contexts and places it occurs. And so where we are trying to go now is how best to do that. So that's why we're doing some of the EMA to say, like, okay, what's happening on a daily basis. Even the one that was 5.9 times a day, they didn't give all the racial discrimination measures every day. So they just gave a subset. So you don't know really, like, you might have missed a whole bunch of things that were happening because they didn't ask the participants specifically that question.
Yeah, no, absolutely. And I think what you were saying earlier too, is that's really powerful, actually labeling it. And because the question earlier about individual level interventions, like policies we need to do, right? But as a psychologist, you can do individual level interventions, and I think that's really important. That some people who are just carrying around this negative affect, right, and like not understanding why, that would be a really interesting and important intervention in and of itself to kind of help people put it in context. And because people, are probably internalizing it as well, right?
Exactly. Yeah.
Yeah.
Which one of the levels I didn't talk about is the internalized racism of them thinking like, oh, I am bad, or I am like X, Y, and Z because this is what society has told me.
Yeah, absolutely. And you see the question from, let's see here. Oh no, here's from Ian. Do you have recommendations did we already cover that?
Kind of. I mean, I can put some that we have used, but I would say none of them are perfect. And a lot of like recent reviews is that we need better measurement, better ways of doing this, but we had to start somewhere. So there's a schedule of racist events that I have used for racial discrimination. And there's like a shorter version, depending, with research too, sometimes you can't ask all the questions that you want to because you don't want to burden the participants. But I can put some, maybe I'll send you a list that I've used and what I'm using right now for my K. People want to be able to include those in their research.
Is your K the one where you're beginning the blood inflammation levels? Okay, yeah, I saw that. Yeah, congratulations on that. So Dr. Sussman has a question. How does segregation contribute to microaggression?
Right. So yeah, so segregation for sure has impacted in different ways. So we can think of segregation within like schooling segregation, right? In the past, we can think now of residential segregation of people being zoned in different areas, which goes back from the 60s, 50s, 60s, when that started after the GI Bill. You can, which is continued today and to some extent. You can also look about like gentrification of different neighborhoods. And what that does is it displaces people from their communities, from the resources and support they did have. So that's more subtle, right? So when we think of racial microaggressions, it's not always those verbal things, but the nonverbal, like you can't pay your rent, you have to leave your home. And now it's, looks completely different with these new communities and people in it, and you're not welcome to, or you don't feel welcome to a certain extent. So that happens, but it, as well as that's also can think about structural discrimination in that way, as well as policies and procedures that allow those things to happen. So that's one way. Microaggressions are very multifaceted, so they can happen in your community store, it can happen in the library, but you can see with segregation, if you have different groups of people or people that don't then interact as much, how then that can have biases and how people view the other group and how that can impact. And we can also think microaggressions. I mean, I've been talking about it as group, but there's also intra-group discrimination among communities that's also important, that can also play a role and come out in these different social circumstances.
Yeah, absolutely. Well, we probably have time for one more question. Given how much social context and peers is a part of substance use, especially among youth, have you looked at how peer level factors relate to measured outcomes? And would be interesting to see if discrimination is from a peer versus someone else versus generalized. That's a cool idea.
Yeah, actually, that's the end of my case. So I do look at the source from peer versus like adult factors. But yeah, for sure, peers are important. There's been also studies looking at how the composition of schools and how that impacts the gender as well as race composition, and how that can impact health, which we would think is substance use, which we think would play a role in that impact of the interactions they're having with each other and discrimination, or more subtle feelings of being isolated or not.
Yeah, awesome. Well, thank you, Dr. Zapolski, for a very interesting and compelling set of studies that hit on so many different areas. And yeah, just like someone said, we look forward to staying tuned for your KO1 study results. And then also, in case we have any early career trainees who are looking to go into clinical psychology, this is a good laugh. Her graduate students do well and doing all sorts of interesting research. So I definitely would recommend checking out Tamika and the IUPUI clinical psych program. So with that, thank you for an excellent talk. And we will, for those who tune into these IAS Distinguished Speaker Series regularly, we will send out in our newsletter forthcoming some updated, future dates and speakers. But this one will be hard to beat. So thank you, and everyone. And yeah, enjoy the rest of your day. Thanks for tuning in. Thank you, Tamika.